All right, well, thanks for being here. I want to start by saying that Brandon Whitten was an all-American kid. He was a football player, a popular student, beloved son, but while playing college football, Brandon became addicted to prescription drugs and alcohol. And addiction would sadly lead to the death of his girlfriend, and 3 years later, the loss of Brandon's own life. Brandon's untimely death profoundly changed his father's life. At first, Reggie Whitten was depressed. Then he was ignited with purpose, starting nonprofit organizations, including the Brandon Whitten Institute at East Central University, and fighting addiction through education that invest in the lives of others and aim to fight drug abuse and addiction. Fighting Addiction Through Education, better known as FATE, has generously sponsored today's event and the video and print media that will be produced. Before we start today's roundtable, please join me in thanking Reggie Whitten and FATE for their support and for their commitment to fighting addiction. Thanks very much. Our panelists today are all experts on this topic. They all have really great lengthy resumes that we don't have time to do, so they're going to get very brief introductions. Michael Burridge is Reggie Whitten's law partner at Whitten Burridge. He's a former U.S. District Judge. He is also the lead attorney in the state of Oklahoma's lawsuit against several opioid manufacturers. Mike, thanks for being here. Mike Hunter is the Attorney General of Oklahoma and has formed a task force to address the state's opioid epidemic. In addition to the lawsuit against several manufacturers, General Hunter is examining physician disciplinary procedures and retail controls. In June, he charged a Midwest city doctor with 5 counts of second-degree murder in relation to the death of at least 5 patients who investigators say received opioid prescriptions without an appropriate medical history. And on Monday, he charged a Tulsa doctor with unlawful possession of opioid medication. Mike, thanks for being here.
Thank you.
Julia Jernigan is the Executive Director of the Oklahoma Behavioral Health Association, which advocates for provider-focused public policies that support a system of well-financed, high-quality, community-based mental health and addiction treatment centers. Thanks for being here. Jessica Hawkins is the Prevention Services Director for the Oklahoma Department of Mental Health and Substance Abuse Services. Jessica, nice to have you. And Dr. Jason Beeman is the Chairman of Oklahoma State University's Department of Psychiatry and Behavioral Sciences at the OSU Medical Center in Tulsa. Among his extensive list of credentials is his board certification in forensic psychiatry. So thank you all for being here today. Our format will be a pretty straightforward question and answer. I will ask one of our panelists a particular question, and then following that answer, if any of our other panelists want to expand on that or add to it, they're certainly welcome, and we'll have to pass you the microphone so that we get your answers recorded. Because we have only an hour, we will try to keep the program moving as best we can. So, Jessica, I'm going to start with you because, you know, why not? I wonder if you could start out, and Jessica, you may, Julia, you may chime in on this too, but I wonder if you can talk a little bit about the opioid problem here in Oklahoma compared to other states around the country. We know we're not the only ones.
Absolutely. Okay, can you hear me okay?
I think the mic doesn't have any amplification, it's just for recording.
Okay, thank you. So good afternoon. Yes, absolutely. The epidemic that is sweeping our nation has really impacted our state here in Oklahoma. We are still among the top of the worst states in the country for things like non-medical use of prescription drugs. We also have had very tragic and terrible consequences related to opioid overdose death in Oklahoma, which has impacted hundreds of lives. Up until just a few years ago, those overdose deaths were rising rapidly. We've seen the doubling, for example, of heroin overdose deaths in Oklahoma. And we know that even our youngest citizens, high school students, report to us really alarming rates of non-medical use of prescription drugs. So in our state, particularly, we've been hit hard by this problem, and needing to deploy the right resources, whether that be prevention services locally or treatments that are needed to address this problem. We've had serious challenges in being able to do that. There have been some areas of bright spot, I would say. In the last few years, we've seen a small reduction in the amount of opioid overdose death in Oklahoma, and we hope that will continue to decline. We've also seen an increase in things like medication-assisted treatment, which we're very glad about, but still those small incremental improvements are certainly not enough. And there has to be more done to address this problem and really resolve the epidemic here in Oklahoma.
Great, thank you. General Hunter, you formed the Oklahoma Commission on Opioid Abuse. Could you tell us a little bit about your goals for that?
I'm happy to, Ted. We're still working to implore all the appointing authorities to populating the commission, so we haven't started our work yet, and we're hopeful to do that here in the next few weeks. But the Speaker, the President Pro Tem, and the Governor all have appointments to the commission, and it's intended, honestly, to bring all of the stakeholders that are really necessary to address this epidemic. And the idea is, let's approach it in a comprehensive way. We're going to look at policy objectives ranging from looking at the treatment opportunities that we have in the state, which honestly are not sized to fit the problem. So between the federal government and states, there's going to have to be investment in rehabilitation, and we'll be speaking to that. Secondly, we're going to be working with the medical community, with prescribers, to see ways that we can strengthen the oversight of prescriptions. You know, and I want to say that the problem that exists within prescribers is a minority within a minority within a minority. But from a law enforcement perspective, as you mentioned, we in the AG's office are going to be very tough when we identify somebody who is abusing their authority, and I think we've demonstrated that. But back on the policy front, we'll be looking at ways that we can provide more education in schools so that we can get this stopped before it starts. But there's also going to have to be attention to law enforcement's role in all this. Because when you're able to begin to throttle back the availability of prescription opiates, you've still got demand out there. And that demand leads, unfortunately, people to heroin, black tar heroin, and other things that are honestly deadly. So we're going to have to be tough with respect to how we deal with the dealing that goes on in the street. But again, the hope is, with respect to everybody on the commission, that we come up with a comprehensive set of policy recommendations for the governor and the legislature to adopt next year.
Okay, great. Mr. Burge, you're the lead attorney in this lawsuit. Could you talk to us a little about the legal strategy for pursuing manufacturers and what the cause of action is and how you approach that lawsuit?
Sure, thank you. The basis of the lawsuit deals with what the pharmaceutical industry has done with regard to the distribution of opioids. And what brought this about is the pharmaceutical industry made misrepresentations. These misrepresentations were made to the healthcare industry, they were made to doctors, And the misrepresentations center around that they are not addictive, they can be time released, and people won't get hooked on them. And this was not only done through drug reps going to see doctors, it was a massive marketing effort started by, there was 3 brothers in New York that were psychiatrists, and one of them had some experience marketing Valium, and he sort of used that as a base model and targeted initially cancer patients. But they went out and got other doctors and to write KOLs or key opinion leaders is what they were, to go around and, to seminars and other events and, say that these opioids were not addictive and they were useful for treating pain. They went another step. They set up what industry trade groups like the American Pain Foundation, the American Academy of Pain Management, and various other groups that were actually funded by the pharmaceutical companies to send the message that the opioids were not addictive. So what happened is doctors were doing what they thought were good things for their patients, and they were following what the pharmaceutical industry had told them with regard to opioids, and it was all false. It was all false, and the genesis of the lawsuit and the basis for the lawsuit are these false and fraudulent misrepresentations that were made to doctors to prescribe opioids so that the drug companies could put billions of dollars in their pockets. Not millions, billions. And it's huge sums of money that they have made. And it's cost the taxpayers of the state of Oklahoma. Tax money has had to go for health care, for treatment, for law enforcement, for the criminal justice system, the courts, and so forth. The cost is staggering, what it's cost the state of Oklahoma. And so this lawsuit is intended to recoup for the taxpayers the money that the state has been out in dealing with the opioid crisis.
Great, thank you. And you touched on a couple of things I know Dr. Beeman's going to want to talk about, and I know Julia's going to want to talk about, especially on the costs, but we'll get to those in just a minute. Before we do, Julia, I want to ask you if you have some thoughts you want to share about why opioids aren't new, right? They've been around a long time. Why are we seeing an increase?
And I think you made a really good point to that. We're seeing an increase because we're seeing doctors that were told that these were non-addictive things. It's interesting because we'll have people walking in saying, my child was prescribed something for their wisdom teeth and now I'm needing medication-assisted treatment. I mean, the warning was not really put there where it needed to be. And I would not put any blame on physicians. I think that there should have been more education, not only for them, but also for those taking the prescription. And so I think that's why we're truly seeing an epidemic at this point, is because it was given so freely without any knowledge. And now we're trying to combat an issue. And it's hard now to be able to get prescription drugs. We're making it more difficult. And so, like General Hunter said, people are going to heroin. And so we're just seeing people increasingly having these issues, and that's why we're seeing the death toll go up, and we're seeing all the different social ills that go with this.
All right, my next question is for Dr. Beeman, who probably by now has a lot to say. But we're going to start with this one. Could you tell us a little bit about what you're seeing in the medical setting in particular, and kind of expanding on the question we asked Julia, how it's changing?
Yeah, thank you. We've seen, in the last, I would say, 15 years, we've seen pretty dramatic changes in the scope. We were, about 15 years ago, right at the beginning of this large initiative to start treating pain. And there was a lot of emphasis in the medical community, especially among family medicine physicians, that you need to start treating pain, even to where they created pain as the fifth vital sign. So we had to document it. Every patient in the clinic, patients in the hospital, everyone had to have their pain addressed in some way. And the guidelines, the professional organizations were telling us the best way to do that is with these long-acting pain medications. And that the risks were not worse than the benefit. And so a lot of doctors started to go towards that. That's changed definitely over the last 5 years, but even more so over the last 2 years. Now there's new guidelines coming, not so much from a lot of the professional societies, but from organizations like the VA, who have really troubled with this problem, and also the CDC. And they're telling us now things that, for chronic pain, don't use the opiates as your first line. And when someone comes in, like Julia mentioned, with wisdom teeth, there's no need for a 30-day prescription of these medications. And we know that your risk of addiction increases after, let's say, 3 days of getting these medications. So a lot of these people that are entering into this problem are your high school athletes who have a back injury, or someone going in for a routine dental procedure. But once they get hooked, they get hooked. And like General Hunter said, once you remove their access to the prescription medicines, then unfortunately we're seeing them go towards the non-prescription, which is right now I think mostly heroin, but we are, I know I am in the department, are really, really afraid of fentanyl, which is a synthetic opiate that is in a lot of other states that have restricted access to the prescriptions, that this synthetic opiate has made its way into the market. So what we've seen over the last 15 years is this kind of roller coaster. And what we're doing at the medical school is now addressing that. And we're trying to teach the young physicians, one, you have to be very responsible in your prescribing practices. You have to make sure that it's always risk-benefit analysis, and that what we're learning is that the benefits of these long-acting medications is not always going to be worth the risk of the addiction that we know is a possible consequence. And we're also trying to teach them different ways to get involved in the treatment once the addiction has occurred, and that's through things like medication-assisted treatment.
I'm going to ask a follow-up question. You mentioned a little bit about how medical education is changing a little, which I want to come back to in a few minutes, but I'd also like to know how clinical care has changed to address the issue. Could you expand on that a little bit?
Yeah, I would say it come in two ways. One is policy, and the other is through guidelines. So policy, the state of Oklahoma has done a lot of things over the last few years to try to get ahead of this. And one of the things that they've most recently done is there's a database that physicians have access to called the PMP, Prescription Monitoring Program. And the state, about 2 years ago, passed a law making it mandatory for every physician to look at that every single time you write a prescription in the outpatient setting that is a controlled substance. So if I have a patient that I'm going to give a long-acting opiate to, I'm now legally required to access this database and make sure that they're not getting it from somebody else. Also in that database, I'm able to look up what pharmacies they're going to. And one of the red flags of someone who's abusing medication is going to multiple pharmacies. So I'm able to access that information and just use that as evidence and information on whether or not the risk or the benefit of the medication works. So there's been a lot of efforts by the state of Oklahoma to provide physicians with more information to make these important decisions. And then also, like I said earlier, there's the guidelines. That the guidelines have first gone from, you know, you should be using these medications, and then now they're to larger national organizations. They're not limited to the specialty colleges of pain management, but now they're larger organizations like the CDC, and they're saying don't treat chronic pain routinely with opiate medications. And now the most recent recommendations have been to not prescribe more than just a few days worth for routine pain problems. So we've seen a shift in what we're being taught and how we're practicing. And that's just on the prevention arm, because on the treatment arm, on how we're dealing with addiction once it occurs has dramatically changed. And it used to be that it would be limited to authorities in addiction medicine, people who only practice in that. But now the CDC in the state of Oklahoma are recommending that all physicians get on the front line of this epidemic and don't send in a patient dealing with this problem to the expert, because they're never going to get in. They're going to have to travel 400 miles to do so. Keep them in your clinic, get the education and certification to treat their problem in their small town, and do the right thing for your patient. OSU has worked with the Department of Mental Health on a lot of initiatives to help make this happen.
General Hunter, my next question is for you. Mr. Burge touched on this a little bit, but you chose to join some other states in suing manufacturers, and I'm curious. We talked a little bit about why the manufacturers might have liability here, but after that, what else are you planning to do, and what's next?
Well, we're going to focus on the lawsuit that we filed, and that lawsuit speaks for itself with respect to what we're alleging. I think Judge Burge did a good job of summarizing what we're contending, and also underscoring the fact that, I'll say it if he won't, we think that this lawsuit involves billions of dollars, not millions, but billions of dollars over the period of time that this oversupply has occurred in Oklahoma. So there's a data point here that is from the CDC, and it's honestly, I think it's as illustrative or illustrative of the problem as any I've seen. Only about 4.4% of abused painkillers come from drug dealers. 17.3% were directly prescribed by a doctor. 66.4% come from a friend or a relative. So there's an oversupply of these drugs, and there's a leakage that's occurring. 2/3 of this supply is leaking into the population, not directly from a prescriber, and it's not being sold on the street. If there wasn't this oversupply, if there wasn't this focus on wealth, not health, if there wasn't this focus not on the patient but on profits, we wouldn't have to be addressing this the way we are. But our focus is the pharmaceuticals. They're the source of the problem, and we're going to hold them accountable.
Okay. Mr. Burge, your job in this particular case is to prove liability. You talked a little bit about some of the facts in the history of the case that you can use to pinpoint that liability in this case. But could you talk, I would think one of the defenses has to be here that both the doctors prescribing the medications and the patients have a role here and have the opportunity to exercise some free choice, don't they? And how do you answer that?
Well, I think you back up and say, why do we have the problem? And it's well documented why we have the problem. We've got the pharmaceutical industry's own documents setting forth, that these are not addictive, that these opioids are not addictive. Now, if a doctor is told that by a drug company, a reputable drug company, he relied on it. And so it's changing now, of course, but back then when all of these fraudulent misrepresentations were being made, all of these industry groups were saying that this is safe, that's what they were acting on. So I think the problem starts with the pharmaceutical industry's misrepresentations and fraudulent misrepresentations they are about the effects of opioids. And that's what started the problem. Now, can you try to spread the blame around? I guess in any situation you can, but the doctor didn't start the problem. The doctor was acting in good faith on what he was told, and what he believed what he was doing was right. So that's where the problem is.
Is there a case to be made against the less scrupulous doctors or pharmacists who are not checking the list, or who are prescribing opioids without a reasonable medical reason or history to do so? Are those other potential cases on this point?
Well, there's certainly liability there if you're abusing the system or breaking the law. That's not the situation this lawsuit addresses. This lawsuit addresses why we have these opioids in this state in such huge amounts, how they got here and why they're here. That's where the lawsuit goes. And like General Hunter said, we're going to focus on the lawsuit and what's in the lawsuit, because we think that we have identified the people who caused the problem, we've identified the misrepresentations, and we're going to go after them. And yes, it does involve billions of dollars. There was a 2005 study by the Governor and Attorney General's tax force that, monetized what it's costing the taxpayers of the state of Oklahoma, and it's, there's the direct cost and indirect cost, but it's over $4.3 billion a year back then was direct cost to the state and to the taxpayers because of opioids.
Okay. Dr. Beeman, I'm going to come back to you for just a minute. And you touched on this earlier, but I'd really like you to elaborate on this. We, over the last at least couple of decades, I think it's fair to say, have seen doctors sort of default to medication when someone comes in with a pain problem. And in addition to marketing efforts of manufacturers, why have so many doctors sort of defaulted to that as opposed to other remedies like physical therapy or occupational therapy?
Well, I think doctors always, hopefully, they always want to do what's best for their patients. And we've already discussed some of the reasons why they were prescribing pain medicines and thinking that they were doing what's best for their patients. But a lot of times patients are wanting the medications, they're demanding them, sometimes very forcefully, and the physicians are under increasing pressures for documentation and to see more patients in shorter amount of times, and to talk to a patient about the alternative treatments for pain, like what physical therapy can do for you, or to perform osteopathic manipulative treatment, which can relieve a lot of the pain conditions, and to talk to them about the non-addicting methods takes more time. And it's easier to write a prescription. And I think one of the tenets of osteopathic philosophy is, even though it's easier to write a prescription, it's not always the right thing to do. And that's what we're trying to reframe our doctors to realize, is that it's an easy fix to write them a prescription, and it might get them out of your office, but you're not doing what's right for that patient. You may be destroying their lives and the lives of everyone around them, and that you need to take the extra time. Also, you're ethically obligated to stay up to date on the latest guidelines. So you might have graduated medical school 30 years ago, but that doesn't relieve your responsibility to educate yourself, because medicine is ever changing. And the doctors have to receive so much education a year to keep their license. The Osteopathic Board mandates that some of that education is in proper prescribing methods and manners. And so the doctors are obligated to realize what the newest guidelines are, and realize that maybe now the opiates are not an acceptable solution like they used to be, and that you do have to take that extra time with your patient. So hopefully we're seeing more of those discussions happening. And I know that they've happened all along. As a family medicine physician, I've had that talk with my patients several times over the last 15 years. Some patients like it, some patients don't like it, but hopefully now we're just seeing a lot more of those conversations happening.
I'm going to follow up on the education component of that, both for medical students and practicing physicians. How do you get that message out? How do you get either that new training or that retraining to kind of a different mindset when it comes to pain management?
Well, so it starts with the medical students, and make no doubt that this epidemic is the public health crisis of our generation. So just like the plague in the 14th century, and then HIV in the early 80s, this is what we're dealing with now. And medical education has had to adapt in real time, and adopt new guidelines for training future physicians. So we're changing things every day. One of the things that we've done at OSU is we now have an entire course directly related to addiction. So just like they would learn cardiology and gastroenterology, pediatrics, now we have to teach our students just on addiction because it's that prevalent and it's that important for them to get that education right at the beginning of their medical career. And then when they go out on their rotations for clinical experiences, now we have to put them in addiction hospitals. We have to get them exposure to patients with those disorders because we know that there's no way for them to not see them as they get older and further along in their career. Once you've graduated and you are a practicing physician, a lot of times you kind of lose that lifeline, especially in Oklahoma and at OSU where we train our doctors to go out into small towns and rural areas. You don't have that lifeline. And so what we've done is, and this is a collaboration with the Department of Mental Health, is we have this initiative called Project ECHO. Project ECHO provides an opportunity for family medicine physicians, really any physician, anywhere in the country, but we gear it towards Oklahoma doctors, to join us by a teleconference once a week, present your patient with addiction, present it to the experts, a addictionologist, a psychiatrist, a case manager, a psychologist, present your patient and let us give you expert guidance in how to treat that patient. We don't want you to refer that patient to us. We want you to treat them, keep them in their hometown where we know they'll get better outcomes. So as part of that, we also provide them with about 20 minutes of up-to-date, most recent evidence, literature, and guidelines on how to treat their patient in addiction.
You use the word disorder, and I don't think that's a surprise probably to anybody in this room today, but could you maybe just spend a minute talking about the physical component of addiction as opposed to choosing to do something for fun?
Yeah, it's very important to highlight that addiction is not what we've been ingrained to think it is through the media, that it is a not necessarily the news media, but that it is a bona fide medical problem, that we recognize it through the disease process. We can show you imaging where individuals' brains change because of addiction. I want to very much stress that addiction is not a moral failure. These are not weak individuals that can just, quote, walk it off. That once they've had that substance, it has forever changed their brain. And I have seen individuals that have been addicted to everything, and they try to take any medicine. So you remove the addicting medications, and then they're trying to use the non-addicted medications to try and change the way they feel. And once you do that, they still want to go outside, stare at the sun, and spin around 13 times just to feel different than the way they feel right now. So this is a real medical problem that we're dealing with, and sometimes incredibly challenging. I've seen husbands spend $2 million on their wives for years and years of rehab and still not be able to make a single dent in that person's addiction. I've seen mothers lose their sons trying everything that they can. It really is an unavoidable problem in some individuals. Some people can take pain pills and have no problem. Some people take one pain pill and their brain changes for the rest of their life.
Thank you. Ms. Jernigan, I want to know if you can talk a little bit about what both the healthcare community in the state and maybe even more particularly the legislature is doing or considering to try to address the problem.
I think that you brought up a great piece with the PMP, the Prescription Monitoring Program. That was something that the legislature did to really try to start combating the issue. But our providers, especially when you bring up the rural communities, are seeing this epidemic firsthand and not having always the resources to be able to see everyone that walks in the door. As a state right now, we have a waiting list to get into some places. So if I walked in today and said, I'm ready to have treatment, there might not be the funds for me there to be be able to receive them. And so that's what we're really seeing is the biggest issue in our healthcare community of, the safety net providers. When someone walks in the door, they might want to treat them, they might want to help them, but if we don't have the space or we don't have the ability to, we're going to have to say, come back when you're a little bit worse. And so unfortunately, that's what we're seeing as time goes on, is the funding is, decreasing, but we're seeing the rise in individuals coming through the door. And we want people to come to the door. We want to break that stigma of that addiction is something, morally wrong with you, and change it to it's a disease and we can cure this, because treatment works. We're seeing it every single day and all across the state in our providers' clinics. And so we're wanting them to come in and get the help that they need. It's just not always the resources there that allow them to be able to get that treatment.
A lot of that answer had to do with money, and Judge Burrage earlier talked about the real costs nationally and to the state. Can you answer that a little bit about what the real costs are in Oklahoma?
Oh, we're seeing it when we have a rise in individuals in our prison system, that are costing $21,000 a year. We're seeing it in foster care with children being put into a system that costs us $23,000 a year. We're seeing a rise in all these different social ills that cost the state and taxpayers thousands upon thousands of dollars. And so, yes, pharmaceutical companies were probably making billions of dollars, but at what cost to us, the taxpayers? And so when we're saying that we need more resources and more funding, it's truly because there are more people coming in the door, and it's not only touching healthcare providers that are giving these services, it's so many different places. You're seeing it in schools, you're seeing it in foster care and DHS, you're seeing it in our prison systems. And so it's not just one area needing the resources, it's now multiple areas that are now trying to combat this issue and trying to be able to pull resources in to be able to give the services again that people need.
Great, thanks. Ms. Hawkins, back to you. We've been talking most recently here about money, and we've certainly all heard about the state's financial problems, especially the last couple of years. Can you talk a little bit about how the budget woes have affected your agency and specifically your prevention efforts?
I think that many of the panelists have touched on this already, and it really can't be underscored enough that for the 800 people in Oklahoma on any given day that have asked for treatment, who need treatment, who are ready to engage in treatment and cannot get services, it's really alarming, and it's also telling about how difficult it will be to overcome this epidemic without the appropriate prevention and treatment resources in the community. I think it also speaks to the stigma that we have with this particular disorder. It's kind of a strange notion to think that for people who are either in crisis or who have overdosed or who have a serious substance use disorder who cannot get the care that they need on demand in the community that they live in, we wouldn't do that, for example, somebody who suffered from a heart attack and tell them to come back later when we could treat them, or that maybe a service for them wouldn't be available near where they live. So really at all levels, in order to get ahead of this problem, not only are we going to have to take on strategies which have been discussed already about really increasing cautious prescribing and scaling down the number of people who are becoming opioid addicted in the first place, but there really is probably no way out of this epidemic without the appropriate treatments that people need. We've seen many promising things by way of family care providers and other providers providing office-based medication-assisted treatment that Dr. Beeman referenced. We need a whole lot more of that. We also need the ability for the local nonprofits and agencies who are serving and partnering with those local doctor's offices to provide the talk therapy for those patients. We need more services there as well. So unfortunately in Oklahoma, the budget problems and also the ability to fully fund prevention and treatment services at the scale that they need to be funded is a historic historical problem. This is a legacy problem that continues to compound. It hasn't improved, but the demand has increased, and particularly with the opioid problem, I would say what we're dealing with here is really an issue of scale. Dr. Beeman talked about it as the epidemic of our generation. I would agree. The sheer number of people who are becoming opioid addicted in our country and in our state is completely overwhelming and unlike what we've seen before. And we need to be able to have the resources to address that effectively.
Your work is mostly in prevention. Can you, number one, talk about what we lay people can do if we have a concern about a family member, a coworker, whatever? What can we do to identify a potential problem and help do something to prevent it from becoming worse? And then any other information you can share about treatments, antidotes, medical emergencies that family members or coworkers should know, what would you tell them?
So first of all, as a preventionist, I always want to be as upstream as possible and not suffer from sort of downstream thinking, where we wait for a problem to occur and then try and figure out how to address it. So in terms of preventing the problem from occurring in the first place, I think we've talked a lot already about probably one of the top important interventions that the CDC is recommending and that states have seen promise in is really improving the prescribing. We need fewer prescriptions. We need fewer days. We need less high-risk prescribing, such as co-prescribing benzodiazepines and opioids together. We need more patient education and counseling about mixing certain drugs that can produce a fatal, very risky event. We also need parents and people in communities to understand how that circulation of excessive amount of prescription opioids can impact their family and young people. So, for example, stocking medications that have expired or are no longer being used, we ought not be part of that cycle of creating a place and access for young people and adults alike to be able to access or divert that medication further into the community. So one of the efforts that we have undertaken at the local level is to really work with not only local law enforcement, schools, nursing facilities, also pharmacies, about safe take-back locations, also places where people can dispose of their medication, and doing a lot of community education on takeasprescribed.org and through local channels to educate people about how risky opioids are, that they are addicting and they are dangerous, and we cannot have them in our homes and communities unmonitored and also unsecured. So disposal and storage is a real actionable thing, I think, that many people throughout Oklahoma can do. Also, we have to talk about overdose risk because one of the most tragic consequences that we're seeing because of the opioid addiction problem is opioid overdose. And thankfully, in our state, we've had some infusion of resources through the state to work on a program for overdose prevention where we are equipping first responders like local law enforcement and also local programs with naloxone kits. Naloxone is a medication that's used to reverse an opioid overdose. It's safe, it's effective, and we have about 24 sites throughout the state now that are providing naloxone kits for free to families, to the walk-in public who want to come in, who may have a loved one using opioids or at risk for opioid overdose otherwise and need to have a kit. That is something that every Oklahoman can think about, can consider, and can take action on locally to prevent this problem. I would say, too, it's important to know that there are resources and supports for families out there who are concerned about a loved one or who need more information about how to get treatment services. For example, by calling 211, operators can have a conversation with families and with loved ones about how to navigate that and also how to intervene appropriately. We have resources on the takeasprescribed.org website, which will direct you locally to treatment providers, naloxone sites, and other things in your area that can help you with those problems.
Hey, thank you. General Hunter, you've only been in office for a few months, and this was a topic that you dove into immediately and kind of a a cause célèbre for you, I guess. Can you tell us a little about why this particular cause, why this particular topic was so high on your agenda?
I think that I would say first that I was aware of the syndrome because I had observed the tragedy sort of secondhand with respect to a couple of little boys that I'd coached as youngsters. And in one case, and we've heard this story repeated, through no fault of his own, young athlete gets injured, is prescribed opiates, and becomes immediately addicted. And ultimately, this little boy is completely recovered, but it was a real tragic episode, for those of us who knew the little boy, those of us who observed the impact on his family. But early in my first, I guess I'm almost 5 months now, Ted, I had the opportunity to begin really understanding this issue with the good graces of a small group of people, very fine people who've experienced it firsthand. And so the catalyst for me was people who I respect and admire, who dealt with it on a firsthand basis, who'd lost family members. And honestly, I just want to say, for the record, one of the things that motivated me to tap Judge Burridge as lead counsel in this case is I knew I wasn't just getting a great lawyer and a great Oklahoman. I knew I was getting somebody who would put their heart and soul into this, because Mike lost his niece to this. So after honestly being inspired by people like Mike and others, it just became something I knew I had to do on behalf of the state. And we're serious about this lawsuit. It's not a sue and settle. These pharmaceutical companies have hurt the state, they've hurt its people, and they've caused the deaths over just the last 3 years of almost 3,000 Oklahomans, and we're going to hold them accountable.
Okay, thanks. We have about 9 or 10 minutes left. One thing that came up in our conversation that I got curious about was whether there's a difference in this problem between rural Oklahoma and the metro areas, either in treatment or in addiction rates or in availability and demand of opioids. And I'd welcome anyone who wants to take a shot at that question to answer it.
I think that we do see a difference, but make no mistake, there's no corner of the state that's not affected by this epidemic. Rural areas in Oklahoma face unique challenges. Usually it's one doctor who is delivering babies and taking care of everyone up until the end of life. Those doctors are forming personal relationships with patients, and they're also treating all conditions. They don't have the benefit of a referral. If you're in a big city and someone has knee pain, you can go send them to a knee specialist. But if you're in the far reaches of the state, you don't necessarily have that opportunity. So a lot of times it falls on them to use these medicines. Also, in bigger cities, you have access to more resources, such as conferences and education and academic centers, where you can help to stay up to date on the most recent guidelines and education. In small towns, you have to run your clinic Monday through Friday. It's hard for you to get away for conferences, and so it kind of limits your ability. With that being said, the rural areas of the country historically have been hit hardest by this epidemic. It's rural West Virginia and Kentucky, Appalachia, and then Oklahoma. So there is some rural component, and I think that goes into historical trauma and the other reasons why individuals are seeking a substance to feel different than they do right now.
Okay, thank you. Anybody else want to weigh in on that, rural, metro?
I would just I would just echo what you're saying about the availability of services and resources, but in addition to that, when looking at overall prescribing, there are differences in our counties throughout the state. CDC just put out a report that showed that although prescriptions are going down, they're still way too high, and we have about 28 counties in Oklahoma that fall into the top category among the country for the highest number of prescriptions. And many times when we look at several different types of indicators, for example, like overdose death or treatment admissions, we see some of the same counties illuminate on the map with a particular higher level of risk. So there is no single one county in Oklahoma that has not been touched by this problem, but there are some distinct differences and regions of the state where there may be particular drivers that are contributing to the problem.
Okay, thanks.
I would just mention real quickly, Ted, back to the complexity of this problem. Missouri doesn't have a physician monitoring program. They have a new attorney general, and I just had a discussion with him, and my question was, what's up? And he just sort of rolled his eyes about the Missouri legislature. So the leakage that's occurring across the state line is cognizable, because you can physician shop in Missouri just across the state line, and so there's honestly a little bit of a phenomenon in that part of the state with regard to frequency of overdoses. So he and I are going to jointly appeal to the Missouri legislature to look hard at a PMP this next session.
You unwittingly just gave us a segue to my next question, so which was about neighboring states and different rules in different states, and how that affects prescribing or filling of prescriptions or availability of those drugs. And obviously there's a concern on the Missouri border. What about the other neighboring states, and how big a problem is it to go shopping in different states?
All the PMPs aren't identical. Actually, ours is a pretty strong, pretty effective one. I think we can make it stronger and more effective. But I will just tell you, I'm having conversations with my colleagues in surrounding states, and we're seeing other states join in litigation against the pharmaceuticals. But there's a lot of interest in having a regional approach to policy that can address just what you've identified, that there's not appropriate similarity, there's not appropriate correlation and coordination between these programs that are in bordering states.
This, again, could be a question for several of you, so whoever wants to grab it would be great. But we've mentioned several times leakage in different contexts. And the first place that came up was that the supply of opioids that are available, and you mentioned, General Hunter, a rather astonishing percentage of the opioids that fall into someone's hands who were not prescribed by a doctor but came from a friend or family member. How do we curtail that, and maybe more importantly, what does the early form of addiction look like when it isn't just someone going to the doctor, getting a prescription for some kind of pain, and then getting hooked on the medication? What does it look like when there's a supply of the drug hanging around, it's getting passed around to friends or family members who then become addicted? What, in real life, what does that look like in somebody's house, or on the playground, or at the school, or at the workplace, or where and how is that happening?
So that can be in different forms. If you do have medication that's left over, Jessica made a really good point. I feel like that's going to be the best thing to start combating that, is getting rid of it, along with the overprescribing. But, you could be around the water cooler at work and someone said, my back's really been hurting me lately. Well, I have Percocets from when my shoulder had a problem. And so it's very innocently where, individuals can say, talking to a friend, talking to a family member, oh, this hurts, or I'm having this issue. Oh, I didn't ever get rid of my medication from this surgery or this issue as well. Happy to give you one. And it's something that just has kind of occurred. The other thing is with our young people is they're looking at this as, going into mom and dad's cabinet. What else do they have access to? And if maybe dad had a back surgery from 2 months ago but never threw away the medication, little Johnny could then go in and try it and see what happens. And so it's this very innocent idea of just medication laying around, but it really has that big impact on not only the individuals that are taking it, but those that are getting addicted.
So somebody mentioned disposal being a real issue earlier. That sounds like that is part of the solution there, is educating people on how to properly deal with medications they no longer need. Fair? We have like 2 minutes left, and I just want to invite each of you maybe to pass the microphone down the line and take just 20 or 30 seconds to give us any final thoughts or follow-up. And I also would like to invite all of you back in about 6 months for a follow-up and see what kind of progress we made. But pick either end and send the microphone down.
I would say the biggest thing is realizing, again, that this is a disease. I think sometimes stigma is our biggest issue, not only when we're asking for taxpayer dollars or if we're just having conversation over coffee. And so continuing that conversation of this is an illness, this is a disease, just like kidney failure or heart problems. And we need to be able to treat it that way, because we would never ask anyone with diabetes to wait until you were in a coma. No, we would instantly treat you. And I think that's the biggest thing as a state and as citizens of the state, that we need to start being able to help our fellow people and realizing that this is like diabetes or anything else, and they need to be able to get the health care they deserve.
Well, when you hear the word drugs, there's a stigma attached to it, like you are talking about. But what the pharmaceutical industry has done is really caused bad things happen to good people, and they need to be held accountable. But it's hard to go out and, when this subject comes up, anybody you talk to, they have a family member that has experienced this problem. And so hopefully, in addition to the financial aspect of this lawsuit, there can be changes in the way that the pharmaceutical industry conducts itself, and they need to be told and have restrictions put on them that the almighty dollar is not the only thing that's that's important, because what they have done is affected many lives, and it's been tragic in some cases.
Well, I've been in public service for a while, and I've always tried to be a lawyer first and a politician second. And please don't roll your eyes about that. I just want to underscore, we're serious about this lawsuit. We've put a fantastic legal team together on your behalf and on the state's behalf. We're serious about this, and we're going to be successful. We're going to hold these companies accountable.
I would just say I think that we're in the middle of a culture change, and anything that each of us can do within our own sectors or spheres of influence to help with that would be appreciated. I know when I started this work in the area of opioids just 4 or 5 short years ago, we really were talking about how to safely use, and probably it's a small portion of people who are abusing and who are the problem, and we have to make sure we don't increase or harm people in pain by addressing this issue. And now, flash forward to today, we really do understand from the evidence and from the outcomes that opioids are highly addictive. They are dangerous. We have to be very cautious in our prescribing and also in our sharing. and not stockpiling our homes with them where we could have negative consequences. So we're all in the middle of helping to reorient ourselves to this problem and find actionable solutions in our everyday lives to help contribute to the solution. I would just add further that this particular epidemic, how we solve this is how we solved other health epidemics. We know what works. We know that the most effective treatments, like medication-assisted treatment, are highly impactful. They make a difference. People recover. We know how to prevent the problem. It's time to bring those resources together. And just also want to thank the panelists and those of you who put this together. It's exciting being in this field to see so much positive energy and interest and willingness to work on a problem like this. So thank you.
And I would just finish with saying that I think everyone here has spoken to the critical roles that physicians are playing in this problem, and that OSU has picked up the banner and are going to fight the good fight, not only in the education of treating pain and safe prescribing practices, but also in the learning and education that goes around addiction and how to treat addiction once it's occurred. So not only are we doing the education, but then also the critical component is the treatment of addiction, and we are dramatically expanding our services, not only in treating patients one-on-one, but we're trying to provide these same services throughout the rural community in the state of Oklahoma so that we can reach the most amount of people possible.
You can learn more on the topic. We will have a transcript from today's conversation posted to the Journal Record website, journalrecord.com, as soon as it's available. We'll also publish in print excerpts from that transcript from today. We'll post both the hour-long video and segments from the video on specific topics that are a little more digestible. Those will be available to some others, including our sponsor today. You can find them at fate.org. We're very appreciative for their support, and I'd ask you, before you leave this afternoon, to please join me in thanking our panelists for their time and expertise today. Thank you very much for coming, and enjoy the rest of your afternoon.